Here's another case presentation from the orthopedic X-ray. The case is a 20-year-old woman has fallen off her bike. She has developed immediate severe pain in the left shoulder and deformity. She has been brought to the emergency department by ambulance and has required morphine to take her comfortable. Her X-ray is taken and this is the X-ray finding. The findings of the X-ray are first of all, we will see the clavicle, and this is the acromion, and this is the coracoid process, and this is the glenoid, and this is the subcoracoid position of the humeral head, which is abnormal, and this should be its normal position. And associated ribs are normal, and lung tissue is also normal. So this is the single AP view of the left shoulder. Shows an interior dislocation of the glenohumeral joint and there is no associated fracture. We will present our findings that this is an AP X-ray of the left shoulder of skeletally mature patient, and the X-ray is adequately exposed with no important areas cut off. The most striking abnormality is the abnormal location of the humeral head lying in a subcoracoid position, and this finding is in keeping with an interior glenohumeral joint or shoulder joint dislocation. There is no associated fracture visible. The bones have normal appearance with no areas of lucency or sclerosis. No rib fracture are visible, and the partially imaged left lung is unremarkable. There are no soft tissue abnormalities, and we would like to view other scapula views, that is Y view, to complete the radiological assessment. The question associated with this anterior shoulder dislocation can be, including anterior dislocation, what are the two other types of the shoulder dislocation which are inferior and posterior? Its detail is the anterior shoulder dislocation is the most common, accounting 90 to 95% of the shoulder dislocation, and it is seen frequently in emergency department, in fracture clinics, and in exam questions. In the anterior dislocation, the humeral head is displaced anteriorly into the axilla and the abnormal contour of the shoulder is lost, and the most lateral bony structure palpable is the acromion. If in doubt, compare the injured side to the normal. Anterior shoulder dislocation are comparatively easy to identify on X-ray. On the AP view, the humeral head will be in a subcoracoid position and no longer articulating with the glenoid. A second view can confirm the anterior dislocation. And regarding inferior and posterior, the dislocation of the shoulder joint can also inferior and posterior dislocation. Posterior dislocation is rare, accounting for about 5% of shoulder dislocation, and classically occurs in patients who have had a seizure or been electrocuted. It can occur with the trauma. The patient holds the arm in internal rotation and is locked in this position. On the AP X-ray, the shoulder may appear to be in the joint. However, the humeral head appears normal. It looks like a light bulb rather than its normal appearance. The second view helps confirm the diagnosis, and it will demonstrate the posteriorly displaced humeral head. So, have a high index of suspicion for a posterior dislocation in patients who present with the shoulder pain following a seizure, and make sure you have adequate X-rays. It can be subtle on the AP X-ray but usually obvious on the second view, and if in doubt, ask for help. Missing the injury leads to significant morbidity, including need for an open reduction and stabilization, stiffness, and recurrent dislocations. The second question is, which of these is or are methods for reducing shoulder dislocation, that is Kocher's or Hippocratic? Its explanation is, there are multiple described methods for reducing an interiorly dislocated shoulder. The aim of the reduction is to restore anatomical congruity of the joint without causing further injury. The inappropriate use of force or performing these methods incorrectly can actually lead to a fracture and nerve injury. Medications such as midazolam or propofol are required for the procedure. To ensure the patient is appropriately relaxed, it is useful to have an assistant. Kocher's method explanation is this is the most well known method for reducing a dislocated shoulder. The patient is relaxed and with the elbow flexed to the 90-degree, the shoulder is slowly externally rotated. If resistance is felt, wait for this to subside before continuing the further external rotation. This may often be enough and the shoulder joint may reduce. However, if this is not successful, you need to then adduct whilst internally rotating the shoulder. This can be done as a quick smooth movement, and this should reduce the joint. Whilst this is the most well-known method for shoulder reduction, it is falling out of favor due to the small associated risk of nerve injury. The other method is Hippocratic method. It is the other commonly used method which you may have seen. The person reducing the dislocation holds the arm slightly abducted with the elbow fully extended. Traction is then applied with counter traction applied by a second person holding a sheet around the axilla. This method works for both anterior and posterior dislocation and is associated with the lower risk of the nerve injury than the Kocher's method. Appropriate conscious sedation and correct technique are both important for successfully reducing dislocated joints. The next question is, what nerve is most commonly injured following shoulder dislocation or reduction? The answer is axillary nerve. And its further explanation given is the axillary nerve is the most commonly injured nerve following a shoulder dislocation. It is therefore important to assess the neurovascular status of the limb as part of your standard workup. This must be done both before and after attempted reduction and clearly documented. Axillary nerve wraps very closely around the surgical neck of the humerus. The axillary nerve supplies the deltoid muscle and the sensation to the regimental patch on the outer aspect of the upper arm. The nerve can be injured either during the initial dislocation or during reduction. Fortunately, the majority of these nerve injuries are minor with good recovery. So, the anatomy and sensory areas of the axillary nerve is very common exam question. Make sure you have this question clear in your revision notes before continuing. The next question is, which bony abnormality is or are commonly seen with the anterior dislocation? And the answer is Hill sacks and bony Bankert. Anterior dislocation of the shoulder in the young are often associated with a couple of common findings on X-ray. The Hill sacks lesion is a depressed fracture created in the cortex of the posterolateral aspect of the humeral head. It occurs as the dislocated humeral head impacts against the interior edge of the glenoid. As the head of the humerus dislocates, it often injures the labrum, the fibrocartilaginous rim attached around the margin of the glenoid cavity. If the labrum comes away from the glenoid with a small fragment of bone, this may be visible on X-ray and represents a bony Bankert lesion. It is therefore vital to assess for these associated injuries. Hill-Sachs lesion is described above. If large, it can cause ongoing instability. These patients may therefore need to have this repaired to minimize the risk of recurrent dislocation. As discussed above, a bony Bankert lesion is also a common associated finding. The bony Bankert lesion is described. If large, it may be necessary to repair this arthroscopically to reduce the risk of recurrent dislocation and ongoing instability. The Hill-Sachs lesion is also a commonly associated finding. The next question is, which of the following complication most commonly occurs following anterior shoulder dislocation in young patient. The correct answer is instability. The other options are pain, arthritis, rotator cuff tear, and stiffness. And its further explanation says that all these options can potentially occur. The patient may have some pain in the shoulder for some time after the injury and may require the physiotherapy to help improve the pain and function of the shoulder. Similarly, the shoulder may be stiff initially following the injury. However, the main concern following this injury in a young person is instability. It is likely some of the stabilizing structures of the shoulder have been injured, and a percentage of these patients will develop symptomatic instability and recurrent dislocations. Instability can be an ongoing problem following this injury. The shallow glenoid of the shoulder allows the wide range of the movement but makes the shoulder an unstable joint. If the stabilizing structures are injured, the shoulder may give ongoing symptoms of instability with clicking and clunking and the feeling that the shoulder will dislocate in various positions. There will have been an injury to the capsule and the labrum may have been injured. If the labrum has come off with a piece of bone, this represents the bony Bankert lesion. Some patient will require an arthroscopy if instability is a problem. So this was the whole about the anterior dislocation of the shoulder joint, which is the main finding on this X-ray, and all the related questions relating about the dislocation of the shoulder joint.